Hello, Don here. Welcome to Podiatry Practice Mastery. We're trying to help you get to the $1 million mark and beyond in your private practice production. I'm going to go over, this is a recording of a Friday. So my Fridays, they tend to run routine in the morning. So that's the half day that I do routine along with my nail tech. My nail tech was on vacation, so it was just me. So basically nail care every 10 minutes for the whole morning, and then we don't really do anything else the rest of the week. So it's a kind of an efficient way if you're not doing something like that. It works really well. I know in the beginning you're like, hey, what day do I do it? Or what happens if patients can't make it? Well, if you just kind of make it that way, they don't really have an option. And if they can't see you in those times, it's a way to decrease the amount of routine care. And I've never really heard of any podiatrist that doesn't mind doing less routine care. Okay, so first patient was Shockwave number 5 out of 6 for plantar fasciitis. He's starting to feel better. The nice thing about doing 6 sessions of Shockwave is that usually about 5th or 6th session, patients start to feel a little bit better. So he is going to do one more in a week. Next patient was a 73-year-old female that was here for a matrix follow-up. So just a reminder, I do 1 matrix follow-up. I used to do 2, but I find that 1 at 3 weeks is sufficient. I've tried to go to none, and sometimes that kind of gives me a hard time because of the drainage and the redness and the concerns that the patients have. I think ideally if I had a nurse practitioner, it would be nice to put all those matrix follow-ups with that patient, with that other physician or treating provider. Next patient was, this was orthotic number 1 patient. That she came in for a neuroma. Wasn't really having concerns right now. Her main issue was frankly first-ray elevatus and hallux limitus, and that's what I noted on the x-ray. So I spent a lot of times talking about hallux limitus, kind of talking about how to unlock that joint, bringing down the first ray, and I find the x-rays really helped me with that. And then she had previously had orthotics, so we made her a new pair of orthotics with the first ray cutout and just kind of explaining the importance of those orthotics. And she'll be back in, it's usually in 2 months. So what I usually do is patients come in about 3 weeks to pick up the orthotics, and then I see them 6 weeks after. So that tends to be about a little over 2 months for the follow-up. Next patient was Qutenza number 6. So this gentleman, he's kind of a challenging one because he has both diabetic neuropathy, but he's also dealing with some chemotherapy-induced neuropathy for his cancer treatment. He finds that the Qutenza lasts about 2 months, and then the last month, the 3rd month, he starts to have more symptoms. And I said, well, that's really ideal. So that's what he has. So we are applying the Qutenza. Just for anyone that doesn't do Qutenza, I find it pretty beneficial. For patients, you're going to know after about three sessions, and if they don't find really much benefit after the 3rd one, I stop it. So I'm only doing it for patients that actually have relief. I'm not going to do it forever on someone that has no relief. The other thing that you might want to consider if you're doing this is I put it on, but then I have my staff take it off, so it saves you some time. It just really occupies a room for that time. You have to have it on for 30 minutes, and it kind of makes a little bit of a mess, but the reimbursement seems to be worth it. Next patient was a 58-year-old female. She had bilateral KeryFlex. She's one that came from our newspaper. She had kind of a really bad kind of onycholytic nail with that was wavy, and she had previously been treated by another doctor, said there was really no option. She was a really good candidate for the KeryFlex. I think it's going to look good for her. She actually came in from one of our newspaper ads because we had a before and after for a bad toenail. Next was also another KeryFlex bilateral. Tis the season for KeryFlex, just so you know. And so she did that as well, bilateral KeryFlex. Next patient was a 75-year-old that she was seeing me a few years ago. She had bunions, and they were painful. I've talked to her a lot about shoe gear. I spend a lot of my time talking about shoe gear. My favorite shoes to recommend are Ultras and Topos, and also we sell in our office Lems as an option. But she has bilateral bunions with pain. I did bilateral cortisone injections, and then she'll be coming back as needed. Next patient was a 66-year-old man who came in. He had been treated in Brazil for ingrown toenails. Kind of came back. He had the medial hallux bilaterally that were affected, and I did matrixectomies, and I'm going to see him back in 3 weeks. Next patient was a 77-year-old man. He came in. He had some balance issues, and he was concerned about some falls. He had He was scanned for orthotics, so this is orthotic number 2, and then I prescribed him some physical therapy for him as well. And then the final patient was, some reason she got in my schedule. She was a routine patient that maybe should have been not placed in that schedule. So that was the afternoon. The morning I didn't put in there because it was basically nail care. My goal, it tends to be for each day to do 2 orthotics, and so I was able to reach that goal today. And I guess the MVP, most valuable patient, would be some of these orthotics. There wasn't really any new Shockwave patients that I could set up today. Okay. Once again, if you guys find this beneficial, love to hear back from you, Don at podiatrypracticemastery.com. Also, if there's other things you're struggling with, let me know. One thing I'm kind of working on is I have a pretty good system for my oral Lamisil. I don't have a great system for my topical. And I've talked to some other people. They really believe in this Intosalin or like Formula 7, and they can do that just as much as I do the terbinafine. I would love to know, I guess, if it works. I just don't really believe in much of the topical, and what you do kind of if it doesn't work. I've talked to some other people. They say, oh, you just do the same thing you do with the oral. Like, not all oral works, and you're right. And so I'm trying to figure out a way of offering more of the one I have is the Formula 7, right? And so I would just use that since I have it. And so all the patients maybe that don't want the terbinafine do the Formula 7. And the other question is laser for like Lunula. I have that. I have Lunula, I have Qutenza. I just feel, once again, it doesn't work, or maybe the patient selection needs to be so selective to have it work. And so I'd love to know if someone really has a great system of how they maybe combine the two, combine the Lunula with the Formula 7. I don't feel ethically I could do the Lunula with the oral medication, because I think the oral works by itself, so I don't think the Lunula was needed. So I'd love to know other people, how you guys do that. Shoot me an email, Don at podiatrypracticemastery.com. Let me know what works for you. I'd love to do that, and if you do share, I will share it with everyone else. Okay, have a great day.